Hello, good morning. I want to say that it's a real pleasure and an opportunity to be here. I want to thank the Program Planning Committee and my colleagues for putting this together. It's really a great distinction and honor to be here. We're here today. Oh, let me start the show. We're here today to talk about teaching and evaluating BAP-MI. My name is Stephen Cole. I'm professor of psychiatry emeritus at Stony Brook and clinical professor of scientific education at the Zucker School of Medicine at Hofstra Northwell. So again, it's a pleasure and opportunity to share this podium with my co-presenters, and we'll move forward. We have no disclosures. First, what are the goals of this symposium? What are we hoping to achieve? We'd like the audience to consider ways to possibly appreciate a self-management support tool, brief action planning, and its step care integration with motivational interviewing, which we're calling BAP-MI, and ways that it may enrich the MI toolkit, especially for practitioners and patients in healthcare. To become familiar with the core competencies of BAP, to become familiar with diverse ways that BAP, in a metaphor that we're suggesting, can bookend MI in the integrated pathway called BAP-MI, and become aware of 3 academic health education programs, and there are 6 nationally, 3 of these where BAP and BAP-MI are currently being used and studied. What is our agenda? I'll start with a brief overview of brief action planning. Then we'll talk about the integration of BAP with MI, a brief overview of the core concepts. And then we'll have 3 presentations of BAP-MI at Zucker School of Medicine at UC San Diego and at Stony Brook Northport. And we're very privileged and honored to have Denise Ernst give us some comments and lead our discussion. I want to acknowledge the co-developers of BAP and those people who have helped in the development of what you'll be hearing about this morning. So, starting off, what is BAP, brief action planning? BAP is a pragmatic, evidence-informed, and versatile MI-consistent tool to support patient self-management and facilitate health behavior change. It's particularly appropriate for those patients who are ready or nearly ready for action planning. That is, for whom ambivalence is not a persistent barrier and advanced MI skills are not needed. And for those of us practicing MI, for patients who are ambivalent about change, BAP functions as a flexible roadmap from evocation into and through the process of planning. So a brief overview of BAP, it's a motivational tool or roadmap, flexible into and through action planning. I want to emphasize that when we teach BAP, it's essential that engagement or connection, rapport, relationship precedes the beginning of BAP. So for those of us in MI, that might mean a high utilization of WARS, core skills of MI, and spirit of MI, emphasizing accurate empathy and affirmation. When we're teaching BAP in more general healthcare settings, and for those people we work with who are not familiar with MI, we emphasize the importance of connection and development of the relationship. In work that I'm doing in the 3-function approach to the medical interview, I call this function 1, or connect. Now, the rest of MI, the spirit of MI, is essential going through brief action planning, and that's partnership, autonomy, support, compassion, and evocation. It is not BAP if it doesn't have MI spirit. And reflecting on this, I've heard other presentations throughout this conference where action planning may or may not have the spirit of MI. So it's important that we think of BAP as infused with the spirit of MI. So BAP begins with what we call question 1. Is there anything you'd like to do for your health in the next week or 2? This is a closed question, and I'll have some more thoughts about that in a few minutes. If the patient responds in a positive way, we'll invite them to clarify and develop an action plan, a SMART one: specific, measurable, achievable, relevant, and timed. Would you like to specify specifics of this plan? Once the plan's been developed, we elicit a commitment statement. So just to be sure we're on the same page, would you mind saying back to me what it is you plan to do? And we know from social psychology research that first-person repetition is highly associated with positive outcomes. Follow this by asking about confidence, about how confident or sure do you feel about carrying out your plan. On a 0 to 10 scale, and for confidence levels below 7, we suggest problem solving be utilized to achieve, if the patient wants or can, to get to a confidence level of 7 or more. And finally, we check on accountability. Would you like to set up any checks on your plan to see how things have been going? In our online course on brief action planning, which is available through the website and through Stony Brook, which has awarded 6 hours of CME with us, we have 160 online outcome evaluations. The appreciation of the program was high. We had 160 responses from people in diverse medical areas, medical students, medical residents, life coaches, social workers, and the like. They thought it was useful on a 1 to 5 scale of usefulness for their future practice, and they felt in their own evaluation of competence to use the skills somewhat skilled and confident to use them. We'll see a video about BAP and BAP-MI that'll clarify this a little more. What is BAP-MI? BAP-MI is a step care integration of evidence-informed skills from brief action planning and MI to support patient self-management and facilitate health behavior change. BAP-MI is useful for patients who are not quite ready for action planning with BAP alone. Patients who may be resistant, or in MI terms now, discordant or feeling distress in the relationship, who may be conflicted in a nicely elaborated way after hearing Alan Zukoff yesterday with horizontal or vertical ambivalence about self-managing or changing unhealthy behaviors. So across a full spectrum of readiness for change, BAP-MI represents a coherent set of step care concepts and evidence-informed skills to support patient self-management and facilitate health behavior change, consistent with MI, and streamlined for efficient integration into the emerging healthcare environment. So we've been working in the last 2 years to elaborate how this works, and we've been presenting it at diverse national meetings. I only want to draw your attention to one here that's upcoming. We are presenting BAP-MI at the American Psychiatric Association summer course, which actually will also be enduring. It's 4 hours of asynchronous learning and 4 hours of a Zoom presentation. And there's the link here if any of you are interested in either enrolling yourselves or passing that to colleagues. There are 2 articles in press, and there's a website with more information. So if we think about BAP-MI, one way to think about what we're doing here is the metaphor about BAP bookending MI. This is a graphic to kind of give you an idea where the books represent the utilization of MI. The giraffe is splitting both sides of MI. Now in BAP-MI, it is important to understand that sometimes BAP is sufficient. Is there anything you'd like to do for your health in the next week or 2? That works. We've tested it, have a lot of experience over 20 years for action planning. For this audience, so interested in MI with good reason, BAP-MI actually may begin, and perhaps most often begins, with MI. That's reflected by this stack of books there. And we're suggesting that the BAP at the end of this sequence is an evidence-based roadmap that can be used with MI. And we want to suggest that quite frequently, and this is what the video is that you'll watch in a moment, where an interaction discussion may begin with elements of BAP. Is there anything you'd like to do for your health? Then we see a need to infuse MI, and then the stage of planning may begin again with BAP skills. So BAP-MI we see as efficient and flexible, comes in many flavors and styles, if you will. And we're about ready to show you the video. I want to give you a thought process that I think involves 3 steps while you're watching this 5-minute video. The clinician at the beginning probes for readiness for action planning with question 1, is there anything you'd like to do for your health in the next week or 2? Patient distress discord emerges. The clinician uses empathy and partnership skills to build connection which may, we know from research, increase sustained talk, but I think it's clear in this case that it softens sustained talk, and I think that's the complexity and richness of empathy and partnership, that in fact it can often soften sustained talk. And I'm thinking, actually I was inspired about ways that vertical ambivalence may particularly respond to deep empathy. If and when change talk emerges, the clinician is encouraged to use MI evoking skills. This is MI language and approach to cultivate change talk. Or, and this is an element of the BAP-MI approach, particularly in healthcare, which is always pushing for efficiency and streamlined and quicker. When and if the patient appears ready for planning or possibly ready, the clinician may reprobe with a modified BAP question 1, which is an adaptation of our familiar pivotal question, MI. Would you like to go ahead and make a plan to stop smoking? So Marina, this is the point at which we'd like to show the video. It's about 5 minutes, and then I'll come back to the slides. So as you think about your current situation, is there anything you'd like to do for your health in the next week or two?
Of course there is. I need to quit smoking. And I'm going to do that. I just don't know when. But my daughter and my wife are all over my case about it.
You're pretty upset.
I do not like people pushing me around. They just do that to annoy me. My daughter is hardly even speaking to me. Imagine that. My daughter, well, that was her own decision. And she's just, she's just not going to push me around.
You're angry.
I've always made my own decisions. I am in charge in my own home. No one pushed my dad around, and nobody's going to push me around. I know I've been sick, but I am not ready to give in and tie on those apron strings yet.
I hear you. You're really angry. You're angry with your family. You've been in charge all these years, and now it feels like your wife and kids are trying to tell you what to do. And you're not going to let that happen.
You've got it now. You've got it.
I can understand why you feel that way.
Don't get me wrong. I know they're just trying to understand and care. They say they want me to be around, but I'm not into that stuff. When your time comes, your time comes. My uncle smoked like a chimney until he was 94. 94. I know I need to quit. And I'm going to quit.
But you're feeling kind of overwhelmed.
I like my cigarettes, especially that first one in the morning.
Oh. Well, it's tough. You're in a tough situation. You don't like your family pushing you around, but you kind of know it's because they care.
You're right. I mean, it's tough. There are times when I think about giving up smoking, I think I'd rather just be a speed bump in the road and let people drive over me. I don't know. Maybe this isn't the time to do this.
I'm impressed. I'm really impressed with how hard you're trying. You're trying to do the right thing for yourself and for your health. And I want you to know I'm going to support you. I'm going to be here for you whichever way you decide.
Really?
Absolutely.
Even if I decide I don't want to quit smoking?
Absolutely. If you want to make a plan to cut down or to stop smoking, that's absolutely fine, and I'm going to help you with that. But if you decide you're going to keep smoking, I'm still here to help. And either way, though, I can see you're really having trouble figuring out which way you want to go.
Well, yeah, it's hard. This is really...
It is
really hard.
It is hard, but we can work on this together.
How do we start?
Well, the starting point would be for you to decide whether you want to make a plan or not. Do you want to make a plan?
I guess I want to start on this.
Okay.
But no one's going to push me. That's not going to happen.
We know that. If it's going to happen, it's because it's your plan and it's something you want to do. So we have to decide. What is it?
Well, I guess I could cut down to 15 cigarettes a day. Yeah, 15 cigarettes a day. That's about right. I could smoke less than a pack.
So that's going to be the plan, 15 cigarettes.
Yeah, but like I said, no one's pushing me.
Okay. So why don't you tell me back the plan and tell me when you want to start also.
Okay, my plan is that I'm going to cut down to 15 cigarettes a day. And my plan is I'll start tomorrow.
Okay. Sounds like a great plan. So let's think about your confidence now on a 0 to 10 scale, where 0 means no confidence and 10 means very confident. About how confident are you feeling about this?
I need to do this. I need to quit smoking. So I made up my mind. When I make up my mind, I do it. So this is a 10.
Good for you. I'm impressed about that too. So you're the kind of guy who carries through with things when you make up your mind.
I am.
Great. So let's talk about when you want to come back so we can see how you've done with the plan.
Okay.
So I'm back now, and I may have neglected to say this is the YouTube link. So what you just saw is available on YouTube in the public domain. So I want to offer some quick reflections before I turn the podium over to my colleagues about how BAP and BAP-MI does use closed questions. Though they're closed, as I said before, it's not BAP if it doesn't have the spirit of MI, nurturing partnerships, supporting patient autonomy, and stimulating evocation. And as we've described over the years, we think that these closed questions are generative. Is there anything you'd like to do for your health in the next week or two? Sometimes we introduce smart planning with a closed probe. Would you like to specify details of your plan? And sometimes we adapt the pivotal question, what would you like to do next, with a more directive, would you like to go ahead and make a plan? In the video we just saw, I was even realizing that I did say what's next, and that was the open-ended version. But we do oftentimes teach it and use it in the closed-ended directional form. Our open-ended rewrites better, and this has been discussed with many people in the MI world. A revision of closed question 1, is there anything you'd like to do for your health, might be, what would you like to do for your health in the next week or two? Or if you'd like to do something for your health, what would that be? Would you like to specify details of your plan? As a way, again, we sometimes introduce the smart planning. An open-ended version would be, what are the specifics of your plan? Like when you'll start, how long? If you'd like to specify details, what would they look like? What's better? What's the difference? Does it impact autonomy, partnership, or ambivalence? Or is the spirit and the music more important than the actual words? Then I came across this writing from Peter Worley just in the last few weeks, which intrigued me. King's College, he's a philosopher, particularly working in the area of early childhood education. And he wrote in 2015, Open Thinking, Closed Questioning, 2 kinds of questions, followed up by a book 4 years later on questioning, 100 ideas for primary tier teachers. Worley's goal, in his own words, was to rehabilitate for education the closed question, because it's gotten a bad rap. A question may be grammatically closed, he says, but open conceptually and powerful for stimulating thinking and learning. In essence, a question may be both closed and open. His example is the mind the same as the brain? Grammatically closed for sure. To me, and I think clearly, open conceptually. Worley encourages an open mindset when using either open or closed questioning. And of course, I'm sure you're thinking what I've been, well, an open mindset in learning, and that sounds a lot like what Steve and Bill talk about as the spirit of MI, as the music for change. So in summary, before I introduce my colleagues, BAP, what is BAP? It's a pragmatic, evidence-informed, and versatile tool to support change. It's particularly appropriate for people who are ready or newly ready for action planning where ambivalence is not primary. And in the practice of MI, for patients who are ambivalent, BAP functions as a flexible roadmap from evocation into and through planning. And what is BAP-MI? It's a step care integration of evidence-informed skills from BAP and MI. Particularly useful for those patients not quite ready for change with BAP, resistant, discord, and conflicted and ambivalent, whether horizontal or vertical. And across the spectrum of readiness for change, BAP-MI represents a coherent set of step care concepts and evidence-informed skills to support self-management and change consistent with MI and streamlined for efficiency. So with that overview, I'm happy to turn the program over to Taranjeet, who's going to introduce herself, and then we'll move on to the other two programs. Taranjeet?
Thank you, Dr. Cole. My name is Taranjeet Kalra-Ahuja. I'm a pediatrician and full-time faculty at the Donald and Barbara Zucker School of Medicine. And I co-lead the communication skills curriculum with my partner, Dr. Joseph Weiner. And we run a 4-year thread, of which BAP is one of our favorite classes that we teach our first-year medical students. So our curriculum is a 4-year longitudinal communication skills curriculum. It starts in the first week of medical school. So as students are being integrated into their basic science classes, they are also immersed in a 7-week communication skills curriculum where they meet weekly. And we start with teaching them how to co-construct a complete history, build trust with the patient, learn how to empathize. And after the first course, then we build on this foundational skill set. And one of those classes that is taught in the spring of the first year is brief action planning. Most of our communication sessions start with a large group framing, which means all 100 students are in the lecture hall and they have an interactive discussion with Dr. Weiner and I about whatever topic that we are going to discuss. So for the brief action planning class, we discussed brief action planning as a methodology and then did a demonstration. After the first 30 minutes, then students are broken up into their longitudinal cohorts. Every group has about 8 students to 2 faculty. It's about an 80-minute session, and those sessions are based off of skill-based training. So we show them a concept, and at that point, then they have an ability to sit down with their family head, which is what the name of these longitudinal coaches, and they're able to practice the skills that they've learned through role play and coaching and re-practice anything that they want to. So when brief action planning is taught is the spring of their first year of medical school. During that time, these students are learning pulmonary, cardiology, and nephrology in their basic science courses, and they're also immersed in clinical experiences in both internal and or family medicine. The way that our session is built is each session has goals and learning objectives. We define the spirit of motivational interviewing, we discuss the steps of brief action planning, and then use the tool to use with patients for behavior change to improve health. And then there is a practice, as I said, in the small group session. The pre-work to these sessions is the web-based introductory training module that Dr. Cole referred to earlier, which is about a 90-minute training module. These are some of the stats that our students also gave after the feedback that they gave for the modules. So as you can see, they highly enjoy these programs. And they also feel that it is useful for them and it is something that they can apply to in their clinical experiences immediately. And this shows their confidence level. So our large group, as I said, is the framing session, about 25 minutes. There's a demo and then students they go into the small group. We have case vignettes because we are a school with case-based learning. So they have a case vignette and they do an initial brief action planning. So students are paired off with a partner in this group of 8. So there's 4 pairs running and each student has their own case vignette. And one student plays the role of a physician, the other plays that of a patient. They go through the initial brief action plan and they swap. And then the one that was playing the patient before then becomes the doctor. We come back after that initial brief action plan is made with each pair, and we debrief that experience and we talk about what was challenging, what was surprising. We talk through it and we allow both the coaches and the students to give feedback to each other. After that, students are then, they go back to their original pairs and they do the follow-up plan of the brief action planning, and they navigate how to then move on to the next step, especially if the patient was not completely successful. And both case vignettes are set up that way, that they're not completely successful, so they are stimulated to then create a plan that's more actionable. The reinforcement that we do in this small group is key. We believe in active learning, and students get that opportunity in this classroom, and then they go to practice this in their clinical experiences, which is fantastic because they learn it in the classroom and then are able to translate that skill to the bedside. And again, we believe in assessment drives learning. The skills that they learn from this class are then assessed in the objective structured clinical examination. So this is one of my favorite stories that I like to share. We had a first-year medical student who learned the BAP skills in the classroom and then decided to practice it. Thankfully, sometimes students are a little hesitant. This student not only practiced it, he was able to successfully collaborate with the patient on their journey towards smoking cessation. And he came back to me and he said, Dr. Huja, I actually tried it and it worked. And he was so pleasantly surprised that he was able to help the patient as a first-year medical student. And I'm very happy to say this student graduated from psychiatry residency in 2020, about 2 years ago. And this is one of my favorite stories of brief action plan. I would like to acknowledge my collaborators here, Dr. Cole, Dr. Frankel, Dr. Fernari, and all the faculty and students at the Zucker School of Medicine and Hofstra Northwell.
So, yeah, Alan, I forgot to leave time for some questions for me or Dr. Ahuja. Oops. Oh, let's see. Oh, I have to go into StreamYard. Do we want to have any time for questions?
I see that there's no questions in the chat.
Oh, okay.
Okay, we can pass it on to Deepa at this
I
point.
think Deepa's ready to put me on. Okay.
Sorry, it took a moment for me to get up there. I did have a question, and it's sort of addressed to both of you. It struck me in listening to the original description at the plan you made in the video was it Mr. Vanguard, and then in the account of the two-step process for the students, to wonder, am I right in thinking that when you make that initial plan, you're actually more concerned, your primary goal is to have any plan at that point, because at the follow-up, there will be an opportunity to talk about what worked, what didn't work, and to do more work if they've already begun to make an effort. And I asked that because it struck me, Mr. Vanguard's plan, I'm going to smoke 15 cigarettes, is not exactly what you would call a smart plan, right? It's a very rudimentary plan. But I could imagine that just the fact that he's committing to something and that the hope is bringing him back, and then how did it go? How can we help? That may be more where the action is. So I don't know. I was just curious if that's also how you think about
it. Taranjeet, do you want to comment or should I go ahead?
I mean, what I was going to respond is this does come up with the students, and we say, keeping a stance of non-judgment and celebrating successes, and then reshaping that plan so it's more actionable for that patient. Maybe they're at a point where that is a small stepping stone, and then you kind of gather them from there and move them on to the next step. So that's sort of how we teach these first-year med students.
And I'll comment briefly, and I'm glad that you pointed that out. The Mr. Vanguard video is actually an advanced video, and people in this audience at ICMI, I'm assuming, have a lot of core skills, so we will not show that video to early learners. In fact, it's not in the online training for BAP. So the goal, in my view, clinically of BAP, and the way I've used it myself clinically, is not so much as to come out with a plan, but offer the opportunity for a plan. So if the patient wants to do it and they have a high enough confidence score, then we'll see what happens on follow-up. And you're quite right that in my mind, the BAP is a process that involves the follow-up and ongoing next steps, because then you're seeing what they've done. And in a shocking way, sometimes we had a student who did a class with me who the wife reported 4 years later, I want to tell you, my husband had been a smoker for 15 years. He was your practice guinea pig. He said, I want to stop smoking, and he stopped. So it's like, it's amazingly powerful sometimes. But in clinical work, Ellen, you're quite right. We follow up and then try it again. It didn't work. So thank you for that.
Thank you.
So are we ready for go on with the next talk? Okay, so Deepa, would you introduce yourself if you're on board?
Yes. Hi, everyone. It's an honor to speak to the ICMI conference. I'm an associate clinical professor at UC San Diego School of Medicine, and I'm the assistant director for our preventive medicine residency. I'm very happy to be presenting on our longitudinal curriculum for behavior change in our preventive medicine residency. So, see here, do I share my slides here? Okay, all right, thank you. So we're gonna understand the role of health behavior counseling and training in lifestyle medicine and describe the development of a longitudinal curriculum for health behavior change and preventive medicine residency. So our context is that that the American Medical Association provided us, passed a resolution in 2017 to recognize 15 competencies of lifestyle medicine, urging physicians to offer evidence-based lifestyle interventions. And this is really considered to be the primary mode for preventing and treating chronic disease. Next slide, please. So in 2010, the American College of Lifestyle Medicine, in conjunction with a number of other stakeholders, including the American Academy of Family Physicians and the American College of Preventive Medicine, published physician competencies for prescribing lifestyle medicine in an editorial in JAMA. And this has really been the impetus for a lot of educational endeavors, including lifestyle medicine curriculum from the CME perspective, but also for residencies. As you can see, one of those competencies is establishing effective relationships with patients and their families to affect and sustain behavior change using evidence-based counseling methods and tools and follow-up. Next slide, please. In 2020, we adopted the lifestyle medicine residency curriculum, which is considered a core competency for preventive medicine residencies. So our UC San Diego preventive medicine residency became a site for this program, and it's quite a vigorous curriculum. It has 40 hours of teaching, of lecture teaching. It has 60 hours of independent application activities where residents are actually implementing lifestyle related behaviors and reaching out to resources in the community. And then they have to go through 400 patient encounters of lifestyle related, implementing lifestyle related counseling, and they have to do intensive therapeutic lifestyle change as well. So that's part of our curriculum as well. And this is in our particular program, this is where the majority of the behavior change counseling comes. Next slide, please. So in terms of the behavior change counseling, we really believe that an in-depth curriculum was important. And so what we did was we created a specific curriculum called RACE-MI, which was Residents Achieving Competency and Expertise in Motivational Interviewing. What we did was, we had residents who were really, really interested in lifestyle medicine. And then there were residents who just wanted to, get the basics because it was part of the core competencies. Those residents who were really interested in lifestyle medicine also were, of course, really interested in becoming adept at behavior change counseling. And so we created kind of an exposure track and an expert track. So the exposure track was just, initial the 6-hour BAP curriculum, the BAP online course, in which they learned brief action planning. We had groups and that were facilitated by Dr. Cole, and as well as over time, my colleague, Dr. Romero, and myself. And we also had a lecture series by MI Mint trained faculty, and they received also personalized feedback on their MI skills as well. In the expert track, residents also went through a course on MI, an online course on MI that we bought for them through the PsychWire website. And they also became mentors for the residents in the following year. So they would go through the BAP course. The first time residents in the expert track would then also facilitate some counseling with the incoming residents in the BAP course over the summer. And they would certify in BAP with Dr. Cole, and they would go through practicum rotation specifically for the BAP-MI curriculum. So next slide. These slides are sort of some preliminary pilot data that we got from testing out the BAP curriculum with our residents. So this one is about how useful they feel the module was for them. And this one is how confident they are in applying the knowledge and skills. So you can see it's kind of most residents were sort of interested and found it useful. And really, at the end of the day, motivational interviewing and brief action planning are about application. Steve and Dr. Cole and Dr. Kutsanok, who's one of our collaborating faculty at UCSD, speak often about the piano analogy, in which you can't learn motivational interviewing by watching a lecture about motivational interviewing. Motivational interviewing is a skill, and so you have to apply it. And therefore, we created some rotations. The residents received individual feedback from their MI skills from Dr. Kutsanok, and then they also had this tailored skills training program in which they practiced BAP. Next slide, please. They also go through the SLIM rotation. SLIM stands for Supervised Lifestyle and Integrative Medicine, and this is a shared medical appointment program. It's quite extensive, but the residents involved in the program, they're specifically there to really practice brief action planning and some MI skills as well. This is sort of their introductory, and so they're practicing BAP skills with patients in Zoom breakout rooms during the program. Residents in the expert track then go on to do a virtual telemedicine rotation. All of this was conceived during the pandemic, so a lot of it was telemedicine. And they are doing one-on-one motivational interviewing and brief action planning with patients over the course of a few months. And then other rotations include the diabetes prevention program and our Ornish program, and they're practicing BAP as well. So these rotations fill practicum requirements for our preventive medicine residency, as well as the lifestyle medicine residency curriculum. So our residents did find our curriculum to be quite meaningful. They found it to be very applicable to lifestyle medicine, and they felt that they were able to really see the progression of behavior change over time. And so we're very proud of it. after these testimonials, we also found out that because of our brief action planning curriculum, another resident of ours was very comfortable with some of the motivational interviewing kind of skills in a addiction related conference, and was then and that played a role in his being able to get successfully obtain an addiction fellowship, obtain admission to an addiction fellowship. So we were very happy with that as well. So I'll take any questions at this point.
Wonderful. There is one question, Deepa, from a participant about the personalized feedback that that you offer to the students. Just some curiosity about how that's done. Is it structured or open, or what's the nature of that feedback that's offered?
Yeah, it was a short presentation, so I wasn't able to, go into detail. So thank you for the question. The way we do it is we have a patient of mine that has been a longtime patient, and she's a kindergarten teacher in her past, and so she loves participating in this teaching program, and really has a lot of ambivalence about different healthy behaviors. And so she kind of is the subject for all of our residents, and we set up a patient encounter with her. The residents counsel the patient, and and Dr. Kutsanak, who is our MI instructor in this case, and faculty at UCSD, observes the encounter, uses, I believe, the Mighty scale to code the feedback, and then provide feedback. And we have residents really from different levels of skill. We've had everything from somebody who wants to, who really has no interest in counseling and wants to do an informatics fellowship later on, to somebody who was really interested in lifestyle and previously was a diplomat at the WHO, and so just really has had. But all of them have really enjoyed the feedback that they received.
Wonderful, thank you.
Are we going on to the next presentation? Okay. So, Deirdre, you're up and can introduce yourself, please.
Sure. Also, my first slide basically is my introduction of myself, so we can go ahead and pull that up. I'm a psychologist that works at the VA in Northport. I have my degree from LaSalle University, and I'm the health behavior coordinator at the Northport VA Medical Center in Long Island, New York. And the health behavior coordinator, I'll get into my role a little bit more. I work in promoting health and disease prevention, and motivational interviewing and health behavior change is the focus of my role here. But in addition to that, work with veterans here and with physicians here. I also am the director of a small psychology postdoctoral fellowship that has a focus in health promotion and disease prevention and interprofessional training in primary care and in other health promotional aspects. So in addition to those things, I'm also a regional trainer for motivational interviewing within the catchment area of the Veterans Association in New York and New Jersey. We call that VISN 2, Veterans Integrated Service Network number 2. So I've been thoroughly trained by VA in training people in motivational interviewing, and I'm also a member of MINT. I will be presenting slides from my counterpart at Stony Brook, Yuri Jadot, who is the associate professor and program director of the preventive medicine residents who train at Stony Brook and also here at the VA for some practical experiences. So I will be presenting on his behalf some of the coursework, similar and different from the coursework you've seen at the other two programs presented here, that he does with the preventive medicine residents. And so we're really looking at how BAP-MI for preventive medicine residents who train at Stony Brook and here at Northport VA, we're looking at how BAP and MI have complemented one another, and I am kind of saying that BAP in a way actually primes these residents to be better learners of MI, and then talk about how our program is developing a little bit. And in particular, we'll focus a bit on what's happening in our smoking cessation clinic here at the VA. Go ahead. Okay, so over in Stony Brook, there's longitudinal training in MI and BAP with these junior preventive medicine residents. So they're having really a year-long course in BAP and also in lifestyle medicine here at VA. So over in Stony Brook, they are taking online training and having coursework, and then they come over to the VA and they actually integrate and do work with patients applying these skills. And also while they're here, and they get additional training in health coaching, something that the VA calls TEACH, which is an MI consistent health coaching tool, and MI training here, which I facilitate with them, and then integrate them into practical experiences with our patients. So from September to June annually, they have 6 1-hour MI practice sessions. So they'll have 12 during their residency. And this is part of their population health rounds. During this time, they actually go through over the course of a year Rosengren's workbook and Miller and Rolnick's latest version of their MI book. And they take the online course that we've talked about already that Dr. Cole has developed in BAP. You can go to the next slide. So when they were asked, how useful they felt that this training is, that particularly the online BAP course was, you can see that they really found it very useful on a scale of 1 to 5, nearly a 5, and how applicable, right, or how confident that they feel they could apply this knowledge in their daily work, and pretty confident at that. So I think this is also similar to the pieces that my colleague was just sharing about, that Deepa was just sharing about kind of why these things are being more integrated into medical residency training and this ICMI requirement, so that there is a mandated formal health behavior change training. They're not saying what it needs to be, but that they need to do this. And so Stony Brook is really embedding MI and BAP in this longitudinal approach to address this need and teaching health behavior counseling skills. And so let me talk just a little bit about health promotion and disease prevention at the Veterans Association, so people understand that I work. This is the VA hospital is the public sector health that's geared towards our veteran population. And at each VA, there is a program to promote health and to help slow the progression of chronic illnesses over time, or help stop the development of them altogether. And we do this in a lot of different ways. We provide education broadly. We also provide clinical services directly to veterans in helping them to enhance their ability to make changes, their understanding of the changes they need to make, of their susceptibility to illness, and so on. We integrate really closely with primary care. We have a medical home model at VA. We call that PACT, Patient Aligned Care Teams. And so we integrate very closely with PACT to provide support to the physicians and nurses working in primary care. And we actually teach them MI, and we teach them the protocol of health coaching called TEACH, which is really a simplified package of MI, teaching MI consistent skills to patient-centered care. And that's actually a requirement. So anybody hired at VA as a physician or a nurse in primary care in the first 2 years of being on board is required to have that training. So I also provide this training to the preventive medicine residents from Stony Brook University who come over here to do their practical experiences. Okay, so as I said, we also have a small health psychology fellowship. And so that fellowship is aimed at interdisciplinary care, interprofessional work. So it's a beautiful opportunity to have the fellows and the preventive medicine residents from Stony Brook actually work together in this way, in this model that we're hoping to promote over time, where patient-centered care is done really skillfully. And so these two groups really complement one another's learning in these factors. So the health psychology fellows are given really intensive training in MI throughout their year. And they're also given training on how to facilitate training to medical providers. So how to actually give MI consistent training and feedback to medical providers over the course of the year. It's part of their competencies for their fellowship. So the fellows and the preventive medicine residents from Stony Brook actually participate together in shared medical appointments with veterans that use an MI therapeutic approach. The fellows are able to observe the residents in real time and provide them with MI consistent feedback. And the fellows are observed in their giving of this feedback, so that they're given feedback on their ability to give feedback. So there's a lot of layers going on here, and a lot of different elements of training coming together with these opportunities. So bringing it back to this piece about BAP, I wanted to really highlight a few of the reasons why this intense BAP training at Stony Brook has really helped us to do what we're doing here, which had traditionally been more focused on motivational interviewing. But as I'll share a little bit later and in our future directions, we're really beginning to combine the two much more. And we're excited about doing this even more over time. But BAP training in and of itself has really helped our preventive medicine residents to come on board with a deeper understanding of the MI spirit. So not needing to really belabor that point. They get that from the beginning, and that helps us to get traction very quickly. They also are primed in the skill of evocation in getting from the veteran what it is that they want to do for their health, and really respecting that, and the use of questioning, right, to be evocative. They're already really used to these concepts. They've seen them, they get them, and now it's refining the practice of them. And they're pretty astute at their ability to recognize opportunities for affirmation and for respecting autonomy in creating plans that are patient-centered with their patients. So now I want to turn to the example I really want to use to highlight how all of this, what this all looks like, is our smoking cessation or tobacco cessation clinic, which is a shared medical appointment. So I mentioned that the psychology fellows and the preventive medicine residents actually integrate together in shared medical work. Our smoking cessation program is a really robust example of this. So we have, at each group appointment, we have veterans who are coming in at different stages of wanting to quit smoking. So perhaps some of them are already quit for some time and continue to come to watch their, to maintain their progress and to watch their colleagues get further along in resolving their ambivalence. Or perhaps it's their very first time and they're just thinking about it for the first time. So we really run the gamut of that vertical, horizontal ambivalence within who is coming, and we never know who is coming on any given day. It's a walk-in appointment. So we have anywhere from a group of 6 to a group of like 18 people coming to talk about various parts of smoking. It could be their first time, or they may be somebody who's attending for a couple of years now. So it's a shared medical appointment. We always have a physician present, and that is typically after they've been trained, the medical resident. But at times, the attending will actually come along as well. And the psychology postdoctoral fellow is also the psychologist in the appointment. But as they're being trained, I am attending as they're to model for them and train them up as well. So they integrate in that the physician is really the expert of nicotine replacement therapy, of any of the physiological aspects of smoking, people with different types of lung cancers, or people with chronic pain, or people with COPD, or other types of issues that they're asking questions that require knowledge of the physiology of the body's systems and the biology of addiction. Perhaps they're talking about withdrawal. All kinds of things come up that having a medical expert right there is really, really helpful, and the most up-to-date, accurate information that's being exchanged. And they're able to exchange this information in an MI consistent way using skills like elicit, provide, elicit. The psychologist is there to more broadly facilitate and maintain an MI discussion amongst the veterans, to use open-ended questions, affirmations, reflections, and summaries to help resolve ambivalence, to evoke change talk. And the residents have the opportunity to watch the fellow do this and to also try it themselves. And as they try these things themselves, the resident is being observed by the psychologist, by the postdoctoral fellow. And then as ambivalence amongst the veterans resolves within any group, there is the opportunity to actually go ahead and use brief action planning to have the veterans think about setting an action plan to quit smoking. So BAP has been a really wonderful roadmap to planning within the smoking cessation clinic. And as the preventive medicine residents have gained more efficacy, they have felt more confident in being a part of these sessions, they really have the skills to go ahead and use brief action planning right there in the group. And so what it entails is really a SMART goal that's being set. We're helping to guide the veteran to set a SMART goal. We're checking their confidence on this, and we're setting this piece up of accountability. So as we're getting to that stage of planning, we have this wonderful roadmap of involving the SMART goal itself, the confidence on that, and accountability to check in on that the next week. Okay. So I think I've laid out here pretty well the pieces that really excite me about this work, bringing together the two disciplines of psychology and medicine together to do this patient-centered work to help resolve ambivalence. As I talked about, our psychology fellows have had some really intensive training in motivational interviewing and coaching in that. And in the future, I'd like to get them trained up in BAP-MI, what we're presenting here, the ability to come in with BAP, use MI if needed, and then return to BAP at the end. So really looking at that book-ended approach and having our psychology fellows really have some more in-depth training in that to be able to integrate that with the residents. And as I said, the psychology fellows are providing feedback to our preventive medicine residents, and they're asking the questions in an MI consistent way of what went well and what could be better. And I want to really keep a better pulse on that and ensure that that's happening weekly after each group. And so that's also my goal for next training year. And then as we said, really having BAP to be the formal roadmap of how we set goals when we set goals for our veterans in the tobacco cessation clinic, and to be able to monitor this work over time. So now if anyone has any questions, I'm happy to stay on for a minute here.
Great. Thank you, Deirdre. I was curious about the very innovative approach of using psychology fellows to give feedback to the residents. The integrated process seems like a wonderful model for others to consider. Just I'm guessing you haven't collected anything formal, but informally or qualitatively, what's your sense of the experience of the fellows in having the opportunity to be able to do that kind of coaching and feedback, and the experience of the residents in receiving that kind of feedback from the fellows?
Yeah, so I have anecdotally, I sit down with the fellows monthly to keep tabs on all this, and weekly for different, supervision. So it is a unique and exciting experience for them. Many of them want to be doing this in their career. And even our supervision is a feedback loop of MI. So it always follows the same pattern of looking at yourself for self-critique and saying, like, what do you feel like went well, right? Which is a question we don't often ask. And one or two things that you feel like could be better. And then my counterpart, who is the attending here for the preventive medicine residents, really recently is a new hire, but somebody who went through the Stony Brook program. And they all talk about this being such a unique, in-depth experience and that they really value it. And my goal is to have the new hire, my counterpart, who's a preventive medicine physician, to actually be more trained in MI, possibly like maybe go for MINT, and I think that will really refine everything.
Great, thank you.
I guess if there isn't anything else, Denise could give some thoughts or comments.
All right. Well, thank you. Thanks for some really good presentations about this program. And a couple of things really struck me as I was listening to this. One is from my own training experience. The whole effort of planning was has always been a part of motivational interviewing, but it was sort of like left to the end and not really highlighted. And in the third edition of the motivational interviewing book, it got raised up and to do planning and to be able to engage in planning as an optional process. And what I have found in my experience in working with coaching people, that the navigation between just doing general motivational interviewing to talk about ambivalence and to do all that stuff, the navigation between that and taking the step to planning has been a very much of a challenge for people. And that there's a sense that they feel oftentimes like they're being pushy if they make that transition. And what I have ended up doing in teaching people about it is that your job is to offer, just like you mentioned, Steve, I really appreciated that, the offering of the opportunity to plan is a really important part. And even in the motivational interviewing book, they talk about it. It's an ethical responsibility almost to offer this opportunity to plan, because if giving people the option of whether or not they want to, and if they are ready, which we may not always know, that if we don't offer it, we have missed an opportunity and may have made the situation worse. And so the BAP has really been, and I have been involved and used it and taught with it, not in the formal sense, but have used it as a tool for many years. And that the BAP provides assistance with that transition. And it provides us assistance in moving into the planning phase and offering that opportunity for someone to consider it. And as that, it's a really important and valuable tool in the MI toolbox to help us navigate that. And along those lines, the structure, which of course has been a discussion in we've discussed it in motivational interviewing, and the use of manuals and all these things that can get in the way. But I also am a very firm believer in providing structure, particularly in training people and moving forward, that having a structure really helps. And the BAP structure, and we hear evidence of that in the training programs, having the structure really helps people to learn and to grow in their skills. So the structure itself provides a great benefit, and particularly in those situations of which we have been hearing about, where people have limited amount of time, and they have also been really well trained to give people plans. So this gives them an opportunity to offer planning as opposed to just handing over a plan. And along those lines, one of the things we've heard a lot about in this conference is about supporting autonomy and about the importance of autonomy support in moving forward. And as I was listening today and listening to the video and reviewing the materials, it really strikes me that every step of the way is completely an autonomy supportive. The questions are autonomy supportive. So what would you like to do? And in addition to creating partnership and that sense of collaboration, they totally support the client or the patient making those decisions for themselves. And so the way it's designed and the way it's implemented, it is a way of training people to actively support autonomy because it flips the way they ask the questions. And so when you take someone who's well-trained in medicine or in many things that are well-trained to ask those questions, and to do them in a way that is not necessarily autonomy supportive, this gives them really concrete examples of how you can actively support someone's autonomy in this very difficult change process. So I think we need to look at how the whole structure of BAP really does fit in that model. And is an important way of supporting autonomy in the process. Besides just the explicit supporting of, this is really up to you, what you do, we recognize, but there are other ways. And that comes, there's a long line of research on the self-determination theory and how that informs autonomy support. And certainly the questions that are used in BAP are in line with that. And so another thing that really caught me, of course, you need to know as a way of self-disclosure that one of the ways that I have been involved in this work is to code using the Mighty and to have discussions with Steve and Katie Hartlieb, who's not here today, about how integrated MI really is with the BAP and where it aligns in terms of our own measurement of motivational interviewing. And so we've had plenty of discussions about that. But what I will say, one thing about the questions, so there is an issue, and I loved the work that you presented, Steve, on the open-minded mindset, if you will. And, we do know from the research that there's not evidence that really supports that dichotomy between open and closed, which in some ways is pretty arbitrary, of open and closed questions as something that is associated with the outcomes or promotes better outcomes. And which is the primary reason we dropped that distinction in the Mighty. So we just code questions. We no longer try to differentiate between open and closed. However, we also heard in the talk yesterday about that what we really are looking at is what is the question actually asking for. And so the questions that are used in BAP not only support autonomy, but are also really likely to put the person in the position of offering to change talk, giving them the option of offering change talk and to move the conversation forward. So I think that is another important distinction that you see. We spend a lot of time training people on open and closed-ended questions, but it may be that we really need to think more deeply about what those questions are actually asking for. And so lastly, I want to talk just briefly about the training and and how acknowledge what has really gone into the development of these programs that you all presented on, about how you really teach skills and how you help people develop and foster their skills, and providing the opportunities for them to actually get feedback and figure out what their next steps are. And there's a good contribution to our understanding about what it takes to actually learn this, which there's a body of research on. And I just want to applaud the creative and innovative ways that you have worked to actively do that skill development and the training. So I think we have a lot to learn from that as well, of how these programs have been integrated into programs, into already standing programs, and really into programs where there's conflicting, where you get a lot of conflicting education even about how you approach patients. So I think that we have a lot. We also have a lot to learn from that. I think with that, I will be happy to take questions or bring the whole group up. I'm not sure they're talking about it here, or whether or not you want me to comment any further, Steve.
Well, thank you for those lovely comprehensive comments. Marina, I thought you were going to bring all of us back and we could just talk with each other and invite other comments, but that was a wonderful, as you mentioned, you've been helping and supporting for years on this, so I just acknowledge your help to the group and everybody listening, you and Katie, who have looked at early traits and told me why BIP by itself was not MI, so that was really important in the integrative strategies we developed. I've been looking a little bit at the comments from the board, and we had one from Kristen Dempsey, I guess, and Deepa, you were starting to respond to it.
Yeah.
I don't know if actually, we won't hear her. But Deepa, do you want to read her question, or let me go back to it, because she typed it in, and I think we should read it. Oh, there it is. I'll read it, I guess. So Kristen Dempsey asks, regarding what Denise is saying about offering planning, I found this very productive. It's about choice, and I find that people do great work choosing small goals. In fact, I have clients that appear to have had their behavior shaped by my introducing BAP. They initiate their own goal for next week at the end of sessions. It's very empowering. I'm interested if you have additional comments about this shaping and or impacting micro behavioral goals. So I offer that, Denise, to you, or Deepa, you were starting to think, or anybody.
Go ahead, Deepa.
Sure, yeah. I'll just say that, our residents have really commented over and over again about how it's been really empowering to watch patients set these goals and then move along the trans-theoretical model over time in terms of their readiness to change by the goals really help with improving their confidence, and they get a lot of practice doing these micro goals because somebody with pain, they might want to exercise in a really vigorous way, but then we talk about their confidence and then they say, well, I'm confident at a 4, and then we kind of are able to then come up with something that they're able to really engage in. So it's really increased, I think, our residents' confidence in being able to address those kinds of issues, and the patients as well. So and we do some education as well during the shared medical appointments about different things, and we talk about behavioral techniques, and goal setting is one of the things that we talk about, and we talk about how it can be so helpful to set small goals, and that probably primes them to a degree in terms of doing the goal setting.
You know, one of the things that I have seen in listening to sessions when these things are happening is that that oftentimes the use of the tools, the use of the brief action planning or the SMART goals or those kinds of tools, in a sense, is really modeling and teaching to the patient about how to do the planning process and what to do, because oftentimes our clients don't come in with they haven't done a lot of planning for themselves. Many of us haven't, but it's a way of actually modeling and teaching that process as well.
And yeah, I was just realizing in terms of moderating this that we turned right to the comments from the group, and I invite more comments from people listening. But Denise, you raised 5 or 6 important themes, and I wonder if our panel wanted to respond to anything you brought up or people listening to. You talked about a transition to planning for MI people, about the structure of the tool, about the infusion of autonomy support and questioning and training, about 6 different things.
Yeah, right away when Denise, when you brought up that piece about transitioning to change planning, like kind of bells went off from just so many trainees over the years before I was really working with BAP, feeling like, you know, MI training stopped at the stage of planning, and then what? Oh, a SMART goal, you know, and there wasn't much of a framework, or we would use that a behavior change worksheet that would like walk them through. And that was like all the structure we really had there, where now I think when we have BAP-MI, it fits so nicely with that trans-theoretical spiral that we might be coming, you know, resolving ambivalence and then coming back into it and then coming back again. And it gives just a nice little structure and a framework. And I've had comments from my trainees being like, okay, yeah, so that's what I can do when I get to planning. And sometimes it's just like having that framework gives you that fluidity or that confidence to know where you're going, where you're helping to guide and follow someone, right?
Yeah.
That really resonated.
Any other, Deepa or Taranjeet, any other thoughts? What we're talking about?
Well, one thing that came up for me was like with it, you know, along the same lines, I had the kind of opposite training kind of trajectory in terms of, you know, first being introduced just didactically to MI, but then really getting my feet wet, my a handle on MI first through BAP. And I realized that I had a tendency to, and sort of the first kind of skill that I had to get my head around in terms of being careful was to not persuade. And I think BAP doesn't work unless you're really not incorporating that aspect of the spirit of MI to not persuade, to really partner with the patient, and you know, and in order to make sure that you're not coercive.
Mm-hmm.
I agree with that, Deepa. I had a patient recently in my pediatrics practice who wanted to incorporate more exercise, and his plan, you know, was 1 day a week. He wants to do just 1 day a week, and I said that's a great start. And let's check in, and we'll see how you did. And so, again, kind of speaking along the lines of the spirit of MI, like, will that 1 day a week really going to make a difference? Probably not, but it's a milestone step towards better health and trust and collaboration.
Yeah. Oh yeah, along the same lines. I think, you know, I think we probably have had similar experience. I had one patient who, you know, after her she was willing to at Wendy's only buy you know, potatoes, and you know, and that was her vegetable, like the baked potatoes, and that was her vegetable. And then the next time she came in, she went on the Whole30. So, you know, it's like, you know, it just goes to show you how it increases their self-efficacy to just set even the smallest goal.
Yeah, I love that discussion, and that fits in with what Kristen was saying too, in terms, and what Alan was bringing up about the longitudinal process. So I've been doing BAP for 15 years at least in my own practice. And I only recently stopped practicing this last year. And in the beginning of introducing BAP to my patients, even in actually in very dynamic analytic practice, I'll say to somebody, and I did, can I shift gears a little bit and just ask you a question that I've been experimenting with? Okay. And so I will never forget this case. So I'm treating this wife of an internist, and I've been treating her for 4 or 5 years with a bunch of neurotic problems, I guess. And she said, when I said, "Is there anything you'd like to do for your health?" She goes, "I guess I should cut down on my drinking." I've been seeing her twice a week for like 5 years, and I had no idea. Well, that's interesting. Tell me about that. I had no idea. And other people, when I started introducing BAP into my just psychotherapy or psychopharmacology, as Alan was saying, they may not have achieved a goal. It might have been not too relevant or it was too high. But then I said, "Do you want to do something else?" And they may say no. But then they come back and I say, "Would you like to make a plan about that?" And they say, "Oh yeah." And by that time they know what a plan is. And it's like what Kristen was saying, that, I really should make a plan to contact my parents or my kids or start walking. And so what would the plan be? And it happens very quickly then because they've done it. I want to make a plan. And then they may come in 2 months later and like Kristen was saying, I really need to make a plan for X, Y, and Z. And at least in my practice, when I started using it so much, it kind of infused the work that I was doing from a variety of perspectives.
I think that what you were saying about the shift from persuasive, being persuasive, and of course in medical professions and other professions as well, that deep sense that we need to advise people, we need to make recommendations, we need to tell them what they should be doing, and of course we do have a responsibility to provide our recommendations and our understanding of what the situation is. And at the same time, this flips it around to where it is you're really drawing on what the patient's strength and where their momentum and energy is. And we know if you start with where their momentum is, you're going to get a lot farther. They're going to get a lot farther if you go with what they're willing to do, even if it's the one day of exercise. But it's that, and again, I think it really goes to that supporting that sense that their own choice, making their own choice about where they want to start and what they want to do and how they want to do it. I mean, all of those things really, as we heard this morning, it's probably a way of really strengthening the prefrontal cortex to be able to make those decisions and to be able to make those choices. So hopefully what we're doing is strengthening that cortex.
So we have 3 or 4 minutes left, but I guess I want to take the opportunity to thank Denise, who is chairman of the program committee, for inviting us and also commenting in such a systematic way on this work, and all 3 of you and your colleagues for putting this together. And it's been a real opportunity and pleasure. And I actually have no idea how many people are listening, but whoever you are, thank you for coming and sharing with us.
Well, and don't forget that they're available for the next month. So
that's right. There may be people checking in later. You're right. I think the next program starts momentarily, actually, doesn't it, at 1 o'clock?
15 minutes.
Oh, there's a 15-minute break.
Yeah, but that's okay.
Okay, I think we're winding up. Anything else anybody might want to add?
Thank you guys for the opportunity working together. It's just wonderful to see how this is similar and different in all these different training programs, and of how it's coming together now to really make a big difference in people's health behavior.
I agree. I wanted to thank you, Steve, for your collaboration and your inclusivity for our program.
Oh, you're more than welcome. You're doing such a great job. It's so great to have Hofstra here.
Absolutely. And I echo that as well. Thank you, Steve, for the opportunity, and Denise as well. It's wonderful to be able to advance this important work and teach trainees from a variety of disciplines and share what we've done. So.
And Deepa is going to be in Mint this fall, so it's a wonderful
Okay.
team.
Yes, I
look forward to that.
Yeah.
Okay, so we'll see everybody. Thank you.
Thank you.
Bye-bye.